Hi, I'm Matt Eisenberg. I'm the Associate Chief Medical Information Officer at Stanford Healthcare. I'm also the Sequoia Project Board Vice Chair. And can you guys all hear me okay? Usually not a problem for me. I have the distinct privilege and pleasure to introduce and warmly welcome our ONC keynote speaker, Dr. Don Rucker. Dr. Rucker is the National Coordinator for Health Information Technology, and I believe still holds the academic title of Professor of Clinical Emergency Medicine and Biomedical Informatics at The Ohio State University. Now, as you know, he needs no introduction to ONC interoperability groupies like me and many of you here in the audience, but he's going to get one because I spent a lot of time on healthit.gov, like what you've done with the place, Don, LinkedIn, and the Google. Now, I do not know Don Rucker personally, but there are several interesting overlaps in our histories that make me feel like I have been professionally stalking him for 40 years. And I'm sure I must have run into him or waved to him somewhere along the way. Dr. Rucker did his undergraduate work at Harvard with a degree in chemistry when my brother David was with him. He was at Dunster House. I don't know where you were at Harvard. He then went to medical school at the University of Pennsylvania, and soon after he left, I showed up as an undergrad. He completed his internal medicine residency at UC Davis. I know people at UC Davis. And my wife started her undergrad career at UC San Diego, and she was at UC San Diego when you were doing your residency. He's board certified in internal medicine, emergency medicine, and clinical informatics, and he's all aboard. That was a joke, sorry, he's a lot of boards. After residency, he spent some time on what we call the farm at Stanford, where I am now. I'm wearing the tie. He completed his MBA, as well as his master's in medical computer science. Back then, they didn't call it clinical informatics. And I was just up the highway at UCSF doing my residency. Now, when Don Rucker started his health IT career, interoperability was going from serial to parallel port, and mobile was talking about houses. In 1988, he joined Datamedic Corporation as a medical scientist and project manager. And while there, he co-developed the world's first Microsoft Windows-based EMR. Over the next 10 years, he served as an emergency medicine physician at the Beth Israel Deaconess Medical Center. I was down the street at Boston Children's doing my residency, and my brother David was with you at BI. He next went back to Philly as clinical assistant professor of the emergency medicine program, providing care at Penn Presbyterian and Pennsylvania hospitals. During that time, he also served as vice president and chief medical officer for Siemens Healthcare, doing what many of us did in the 2000s, putting in EMRs and CPOE. During that period, he was part of the team that at Cincinnati Children's Hospital that won the HIMSS Davies Award in 2003 for their implementation. I was a HIMSS Davies Award at Multicare winner as part of that team in 2008. He then served as the CMO for Premise Health, working on population health, EMRs, quality improvement, and analytics. He's practiced emergency medicine at Kaiser in California, OSU Wexner in Ohio. He is a fellow at the American College of Emergency Physicians. He remains, I believe, licensed in only 4 states right now: California, Ohio, Pennsylvania, and Tennessee. He served on the board of commissioners of CCHIT, Medicare's Evidence Development and Coverage Advisory Committee, or MedCAC, and his extensive policy experience in representing healthcare innovations before Congress, MedPAC, and HHS. Despite my internet sleuthing, and until a few minutes ago, I still haven't figured where he came from, but he's from New Jersey. I grew up in Long Island, not too far. I do know he has more than 500 connections on LinkedIn, and I only share 11, so I have some work to do, Don. Regardless, we are really honored and delighted to have him with us today. Please join me in warmly welcoming Dr. Don Rucker.
Wow, you don't normally get an introduction like that. It's somewhere between flattering, oh, I'm old, and it does seem a little odd, but you know, what does it matter? We're all nerds, so I think we have to. I think we have to self-identify to our behavioral tendencies. Well, first of all, thank you very much. It's great to see such a wonderful audience and such a large audience at Sequoia. We're obviously, as you know, from multiple ONC speakers at the event, including Rachel just a moment ago. We're very excited to be part of your world and really see our role as facilitating the type of interoperability and the work you do every day. And so then the question is, what are the best ways to help with this nationally? And so that's what we're going to talk about a little bit here today. I think we have to, as we think about interoperability, and interoperability has changed. We didn't even really have networks when, a lot of the EHR stuff got started, when you get right down to it. But I think we've made a vast amount of progress. But clearly, when you look from outside in, so inside out, I think we've seen a lot of progress. But outside in, I think there's still a great unhappiness in the American public with what they're getting in healthcare, the ease of healthcare, and frankly, the gap in, let's say, computational services in healthcare with the rest of the economy. We all sit on our smartphones. Probably half of you are looking at it right now. When's the next speaker coming up? I get it. I might have done the same thing once or twice myself. Not at a Sequoia event, but other events. So I get it. But the serious part is, we have created as a country, as a world, as an economy, highly immersive events on our smartphones. And in every part of that, besides healthcare, we're having some interesting discussions, and some of the lobbying on the Hill on, the app economy, and it's the FTC has a nice report looking at the impact of the app economy, but they call out that there's like a huge gap in healthcare in the economy. So I think we have to think about how do we get interoperability in that seamless world into healthcare. You're obviously doing a vast amount there. Congress saw this same thing. It's interesting, you talk with members of Congress, and often the conversation is not about some specific policy per se. At least initially, it's, I went to the hospital wherever and I couldn't get my medical record or my mother's medical record. Those are the types of conversations that I think anchor many of our experiences, including, personally, as we do it for ourselves and our families. So Congress, as folks know, in the 21st Century Cures Act said, we're really going to mandate and double down on this interoperability event and activity. And so I'd like to give you just a progress report on where ONC is with that. As folks know, the way the laws basically, including 21st Century Cures, they have the secretary shall. So if you were to engage in a pre-sleep exercise and read the 21st Century Cures Act, I know there's some people, Lindsay here, probably read it when they were awake, but because they had to. But if for the rest of us, it's dry reading, no doubt about it. But in that, so Congress has the broad outlines, and then the agencies like ONC have to do the paint by numbers on those broad outlines. So let me talk about 3 areas in specific and some of the surrounds. So we'll talk about information blocking and the thinking there. We'll talk about application programming interfaces without special effort, and we're going to obviously talk about TEFCA. So the information blocking part, obviously the goal there is, and this is the law as we speak today, is Congress said, patients have a right to their information that shall not be blocked for business reasons. And, that's a complicated issue because it's a fine line of, I don't feel like doing it, hell no, I'm not going to do it, or it's hard to do, or I don't know how to do it, or I don't have the tools, or there's a lot of complexity involved in the concept of information blocking, and it's really a sort of a gradient, a relatively challenging area to draw the exact lines. So in the proposed rule, we have a number of provisions. So one is just if there's obvious direct harm, and you can imagine some sort of edge circumstances there that would be potentially real. There are some broad protections against issues with security and privacy. I like in all of these discussions, they're often merged together, but I think for our sanity, we have to separate out security issues, which are, I think, often very technical issues, with privacy issues, which are really more policy and business issues, I think, in many cases. But they're so we've separated those out. There are, we want this to be practical, so there are, it won't be information blocking. What we do are the exceptions to information blocking, is what Congress asked HHS to do. So what we're defining in the Cures rule are the exceptions to information blocking. Those exceptions include a general feasibility. If somebody has a request for information that's just not technically doable in any way, shape, manner, or form, that's allowed. If there are issues, for example, as an ER doc, most server upgrades, EHR upgrades, they all seem to happen between 2 and 3 a.m., right? So the IT staff, they can stay awake till 2, maybe 3, nobody's really doing anything in the hospital that hour. But if you're in the ER, and by your, and especially if you're in a smaller department where you're the sole doc, it's a bit of a wrenching experience at 2 a.m. to figure, where do we do where are our paper chart backups, and start pulling those out for an hour. So we have feasibility there. There are 2 important provisions. We have had many people come to us in terms of information blocking and say, XYZ entity is charging us so much money that in essence it is information blocking just by the cost structure. So if you read the law literally, any charges for APIs would actually be information blocking, right? Something that is is not free is sort of a quote, a block. We obviously want to be able to have APIs and have people make money on APIs and put resources into APIs. So we have exceptions allowing, frankly, very loosely defined on reasonable cost recovery, as well as concepts of thank you very much, costs reasonably incurred. And we've gotten some pushback. Well, you use the word reasonable 300 times in the rule. I tell the folks, we use the word reasonable for a reason. It's not because we have a poverty of vocabulary or because nobody at ONC was able to spring forth thesaurus. Right? We use the word reasonable because we want it to be reasonable, as opposed to at some point down the road interpreted in some kind of, sort of querulous, narrow manner. We want this to be relatively broad. However, if you have an API that is identical to another one and you're charging somebody, $1 million for something that had no particular work on your part other than punching in an IP address and, and providing the bank account for the check, there's an issue there in terms of interoperability. So there are components there. So that's the information blocking part. I've referred to the proposed rule, as you know, and as many of you provided. We have 2,000 comments that we parsed through. When I was on the other side of the fence, where I spent almost the entirety of my career, a number of times at Siemens, I was the lead comment letter writer person, or the marshaller of. So I've written many responses for RFI to government agencies. And I was always curious, does anybody read this stuff? But I assure you, at least at ONC, and I think it's actually true throughout the government, not only are they read, they're meticulously analyzed, and we map every comment in those letters to every part of the relevant rule. So there's an elaborate process to make sure that we've incorporated the public thinking here. So much for information blocking. We're going to have some time for Q&A as well. The next area is the concept of application programming interfaces without special effort, which obviously we've sort of hinted at that with the information blocking provisions. So what Congress wanted there pretty clearly is that the APIs that power the app economy, right, the Ubers, the Lyft, the banking, all of that, that we want that in healthcare, right? We want these sort of, what in software, it's not a current term as much, but it used to be called mashups. We want those things that synthesize value add into new, new services. I think Uber and Lyft in many ways are the very best examples of, many APIs coalescing into something that's totally different. We're hoping for that kind of stuff in healthcare. We'll see how that plays out, but I'm quite optimistic that we're going to see totally new services that maybe some of you can imagine and build businesses around. That when you look at the API world today, and I know there's, and I know the HAE world is built on somewhat older standards, so part of, I think, the whole Sequoia work and the recognized coordinating entity is as we sort of make these various transitions and take the best of what we have and the best of what the things that are coming up. But if you look at just apps as apps, so without all of the identification and networking issues that HIEs have to deal with, there it's that RESTful JSON FHIR stack that is really dominant. So RESTful are the gets and puts. You see on browsers, JSON is a very elegant data representation, and FHIR is obviously fast healthcare interoperability resources. We are very supportive of HL7's work in doing that. We've funded and continue to fund some of that. ONC has funded the Argonaut project that really fleshed out the details of these APIs with Ken Mandel and the Boston Children's Group. That started with one of the original SMART grants that dates back to David Blumenthal and ONC in, I want to say, 2011. So, we're really harvesting now, I think, a long track record of work. As we look at APIs, we're also putting in, and this is not necessarily for anything per se in the Trust Exchange framework, because this wouldn't, I think, really happen that way, at least in our concept. But we're also putting in what we call a population level interface, a bulk data interface that allows a query, let's say a payer wants to see performance of a whole bunch of patients at a provider. And so those, because the classic smartphone APIs, an individual patient using OAuth 2, so that individual patient picks an app of their choosing or apps of their choosing, and then that app directs them to the provider endpoint, and the patient has to log on to the provider endpoint. And that's a very volitional act to do. The population level data is really a very different beast. Technically, it uses the exact same FHIR underpinning, presumably, some of the same potential driver, database driver functionality. That is a transaction under HIPAA, right? Those are transactions between covered entity and business associates. So there is nothing, I know people said, that can stop the network and slow it down. The bulk data transfers are things negotiated with written contracts under HIPAA between covered entities and business associates, or some similar legal construct. That's not part of the on-demand part. That's just something we're doing to really, in the spirit of coordination and APIs without effort. So just to make that clear. The big issue, I think, as we look at all of this data, whether it's coming through an API or coming on a smartphone or coming through a health information exchange type of activity, are the issues of security and privacy. I think security we have some very powerful technical constructs that, at least in computer science, as we sit here at the end of 2019, seem to be robust to, as robust as we can make things to hacking, cryptographically sound. So I think that, with the OAuth 2 protocol, that works in many high transaction value industries, banking, defense. So I think we have that. The privacy question is an interesting question, right? Because what we're balancing there is the individual's right of access, right? So this is a different part of HIPAA that has not really been in the computer conversation at all, right? Because the part of HIPAA that we think about is that treatment payment operations part, the authorized thing that, then those exceptions that allow transmission. This is something that has never really been much in software. There's a little bit of language, so I'm exaggerating a tiny bit, but this is really in the smartphone economy is a new concept, which is the computational right of access. So we have to balance the right of the patient to control their own lives, control their own data, have a handle on the costs, the money they spend on healthcare for themselves and their family, important things that we've absolutely failed at in the American healthcare system over the last 50 years. Article after article after article, and of course all of our personal experiences. When we go to the doctor or to the hospital, hopefully not, right? We have very little idea of what it's going to cost us and very little idea, I think in many cases, of what we're going to get for that service. So the right of access is critical. And then you have the questions of how do we protect privacy there? And what we're talking about is really secondary uses of data. I believe you will see in the rule, we're looking at, right now there's not a lot of federal law on privacy. We don't have anything like the European Union does with the GDPR or the California Consumer Privacy Act that are, those level of protection. So right now, there are many bills on the Hill, but right now the protections for privacy are related to deceptive business practices enforced by the Federal Trade Commission. So if you remember back, whatever it was, 2 months to the $5 billion Facebook settlement, that was around deceptive business practices. And so the Federal Trade Commission not only fined Facebook, but they also got Mark Zuckerberg to sign an agreement that makes him personally criminally liable for breaches in that. So, that can be a very powerful tool, but so what we're doing, and there are a number of other things that the FTC has authority over, including unfair business practices, which would be not a federal action, but a private cause for action for the lawyers in the room, as well as there are a number of state laws on state causes for action here. So to bind those in, we're looking at how in this OAuth 2 process we can put a consent into that slipstream in a way that is as clear as the very process of OAuth 2 logging on to get your data, right? So this is not something where, pretty much every day we have to click through some end user licensing agreement. You see that now at the bottom of the screen, on your phone or your web app, blah, 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 click X if, by using this you agree to whatever. So this is not one of those end user licensing agreement or, when your iPhone or Android has a new operating system, this huge legal contract, agree. Right, this is not that. So that the world of secondary use of data, I think, is still evolving, but I just wanted to give you the status update of where we are on that. So having now talked about information blocking and the APIs, let's talk about TEFCA. And so I was wondering what to call it when I first read the law, but I guess TEFCA seems to work. Trusted Exchange Framework Common Agreement, that seems to have a sort of a pretty straightforward logic. That's what Congress called it. they voted on it almost unanimously, so why don't we call it TEFCA? I'm sure one of these days, TEFCA will be like HIPAA. Nobody knows what it stands for. Your only external link to know that the people have at least some idea of what might be in HIPAA is if they spell it right. So, if they tell you about HIPAA, they're a HIPAA expert and there are 2 P's in HIPAA on their slide, you may want to go to the next talk. There's probably something, probably the knowledge might be a little bit more superficial than ideal. Of course, TEFCA has no repeating letters, so it should be easier. But the concept there, again, is how do we have these trusted exchange frameworks to share information? Congress, the animus for that was Congress got a lot of complaints on I'm being asked to join multiple networks. There are multiple charges. Get these people to talk to each other. It was, as if you've had a chance to read it, not heavily specified. And so obviously what we're doing, as folks know, is we're using the concept of a nonprofit recognized coordinating entity, Sequoia, that's why you're here, to really have as much of a private sector activity, a voluntary activity, as we possibly can. As you might imagine, as a Republican political appointee, if we try to start with the private sector, and that's a bit of a challenge because pretty much all of healthcare has been created by government policy, so it's a bit of a challenge. Leave it at that. What we're required to do under law is have some. We can't just. The government cannot just totally contract out to private entities to run things. So we have, the government supervision of this process really are the minimum required terms and conditions. I think you're going to have a lot of talks and slides on this here, so I don't want to repeat that. I know Marianne has a great slide deck on going through that, but think of the MRTC really as a way to just make sure that it's a fair playing field, that the interests of the patients, including their economic interests by, via the payers, some of the broader public policy things on, for example, the Social Security Administration, on disability, some of the public health things that are part of the American social fabric, that social fabric is supported and well supported to give legs and fuel and momentum to the whole TEFCA process. Obviously, you're working here on some of the exact details on what the technical underpinnings are. I would take the QHIN concept not as something created from the gods of computer science, but really a policy construct for Sequoia as the RCE to really sort out. The goal of that was really to support query, right? Distributed query, broadcast query, potentially targeted queries. So it's really seen as a mechanism to support query, and I think we will certainly be supportive of anything that gets people to the data in a way that works for you. So don't anchor on QHIN as QHIN is not quantum mechanics. That's not what the Q stands for. It's not like there's only 2 electrons in the first shell. You might have remembered from high school or college chemistry. It's a creation of man or woman, and all of you. And so think of it in a way that makes sense to you. We have great hopes as we think about the various players. A couple of policy concerns here. We are concerned on single vendor only networks. We want to have a competitive world where everybody gets data and that you don't have to be buying one vendor's EHR product at great cost and buy into an ecosystem where there's no price competition or maybe no competition whatsoever in selected geographic areas and markets. We want this to be that the low-cost imaging center, ambulatory surgery center, the urgent care center, the freestanding ER, that all of these people who can, individual practitioners throughout the country, that all of these people can have an economically viable way to share information in a way that, meets the public needs. That is the clear spirit of the Cures Act. I think another high-level policy goal, and we have Mark Vafiatis here. Mark, maybe if you can just raise your hand here, who leads our efforts with John Rancourt, the rest of our team, John in the back, and we have a number of folks, so apologies to the rest of the team, to get some of the broader surround, so the social determinants of health, community information exchange, which I think HIEs are just perfectly positioned to do because you have local resources, local knowledge, local, this is an ugly phrase, but in DC, boots on the ground. It seems sort of, martial arts kind of, or, militaristic, but, you have that local knowledge and ability. As an ER doc, I have spent decades, because most of my ER career has been in 3 big ERs that have done a lot of psych, behavioral med, and substance abuse issues because other parts of those towns didn't want to do them. And so I have taken care of literally thousands of patients who get ping-ponged through the system. They get ping-ponged between the group home, the shelter, jail, increasingly schools, not maybe fully functioning clinics. And they're always hot potatoes. We know the last person who sent them to the ER, but we really don't have any real visibility into that care trajectory. Obviously, the country now as a whole is starting to understand social determinants of health are a very important part of that. So I would encourage all of you, as you think about the Trusted Exchange framework, to think about how we can put in some of these community resource, blend that in, so that this takes the entirety of the information we need to take care of patients well, and not just the most medicalized slice, the licensed doctors, the licensed hospitals, but really the broader surround. So we're looking forward, obviously with interest, as they say, on how this all plays out. We want to be supportive. You know how to get a hold of us if there are concerns from any one of you on what's going on, how it's playing out, what we've missed, what we should be doing, what we should not be doing. We're pretty much all ears. I've had probably well over, I think a good bit over 200 stakeholder meetings in my, whatever it is, 2.5 years at ONC. So we try to run an open door policy and meet with everyone. So with that, I think we have time for some questions. Is that, I don't know, Matt, I don't know how you want to manage the questions and how much time you want to allocate for questions, but definitely, I know we have a couple minutes for questions.
Yeah, we at least have about 5 minutes for questions, if you can do that. And please come up to the microphone, introduce yourself, please, and we'll take it from there.
I have more a comment.
Or comments are fine too. Okay. I was just going to say, comments are fine too.
I have more a comment. My name is Ann Kimball. I work at High Trust, and really keyed into ONC's look into privacy and security. Really applaud the fact that you guys are understanding that there has to be flexibility in the standard. Talking about reasonable security, talking about reasonable privacy, because those things change over time. Very important. What we would suggest is that one of the problems in the privacy and security space, particularly with non-HIPAA data, is what does reasonable mean, as you said. And we would suggest that one of the things to look at is our privacy and security certifications that are being done by the private sector. Not surprisingly, I'm biased and I think we're the best one, but there are other ones going on out there, and sort of help recognize or consider recognizing those types of programs, not necessarily one, but those types of programs, so that particularly people dealing with APIs or social determinants of health who don't have HIPAA data, but want to be able to share that data, can say to their partners, okay, I do have reasonable privacy and security. And so recognizing what the private sector has done in this area, we think would help a lot to get the system up and running.
That's a great point. The secondary use of data thing, there was a proverbial cited study, Deb McGraw, I know, cited in her blog on, I think it was McKinsey, one of the consulting firms, said there was 2,700 times as much HIPAA covered data that you could infer health information from as, quote, HIPAA covered data. So in a world where you can infer everything about your health from your GPS, are you at the bar? Are you at the HIV clinic? Are you at McDonald's? Are you just not moving at all? Right, your accelerometer, we have so many ways to infer data that I think we still need, a broader, the watches. There's a lot of congressional interest in how to go about this discussion. Obviously, the GDPR, the European General Data Protection Regulation, has essentially forced the hand of this. I think there's way more discussion to be had in that, but I think your point. Yeah, thanks.
Jill DeGraff, I have a little bit of an update on that because there was an important privacy hearing yesterday in the Senate. And I will simply say for everyone's benefit, contrasting with some of the other more political and partisan activities on the Hill, there's remarkable bipartisanship in the area of privacy. And what is coming out loud and clear, not just for health data, but for other ways that are sort of invading on individuals, there's a recognition that our sort of permissionless notice and consent model is failing individuals and putting too much of a burden on them to investigate and monitor and protect their privacy. So the balance is now shifting significantly with broad bipartisan support towards greater transparency, more corporate responsibility, and greater enforcement. Those are recurring themes that seem to be widely applicable, certainly influenced by CCPA and the European Union's GDPR. So personally, I'm quite encouraged. And to the issues that were coming up in many comments by members of the healthcare community expressing concern about what's going to happen when the sensitive data is out there, that concern is widely shared in the broader community and the policymakers. Personally, I'm quite encouraged.
Yeah, no, I think that's a nice summary of the nature of the issues. I would just, as you think about this, it's just from a analytic framework. It's worth thinking about. One of the ways of doing this is the way HIPAA does it, which is just limiting it to certain permitted purposes, right? So there are a number of different ways you can frame privacy regs. Any other questions?
Don, I'll take the last one and then let you go. It's
Okay.
Matt Eisenberg. Before you got here,
You're right in the brightest of lights, so.
sorry about that. I'll take the prerogative. We talked earlier before you got here about information blocking. The Sequoia Project and Interoperability Matters Group have done some remarkable work to prepare our members and others for that. So one is a pointed question. We had a lot of tea leaves. We want to know what your tea leaves are about when we'll hear about information blocking with the final rule. And two is they've put together a great framework. In fact, I wrote down some things. I mean, we're going to have to change our notice of privacy practices probably for information blocking. We're going to have to go back and redraft our BAAs. We're going to have to put together our groups in compliance and legal to understand that. And I'm sure after I do my HIPAA training once a year, I'm going to start doing my information blocking and soon my TEFCA training, and hopefully I'll remember how to spell it. So I guess the questions I have for you is any tea leaves about what we should expect, and how long do you think it's going to take us all to get into that space? It took us a long time to sort of understand HIPAA and implement it. Had a lot of nice templates from OCR about how to do that. This is going to take some time.
Yeah. So obviously I can't give you an exact date for when the rule is going to release, A, because I don't know, and B, but we're hopeful sometime around, let's call it the end of the year. The end of this year. Let's leave it at that. We're trying to make, I think you can look at skipping some of the operational things, and I would put TEFCA into operational activities, but in terms of more regulatory, the APIs and information blocking, I mean, we're trying to make this a pretty straightforward thing. You know, you provide a fire endpoint type of thing, as opposed to something that has lots and lots and lots of complexity. We are going to have a whole bunch of materials. We already have a lot of stuff on the website on that, but we'll have a lot more materials to educate people on that. I think there is an evolution. I think you're going to find that in the rulemaking there will be time for people to learn what's going on and have a period where people can sort of sort it out without immediate legal penalty. I think you're going to find that, if I had to guess. I think we'll be able to do it that way. But there will be a different, I think Congress clearly intended, I mean, that's the whole point of the law, or that section of the law. Congress intended that there be, a different set point on this, that, patients are, have a right to their data, and that right has to be operationalized. It's, not enough to have it as an abstract concept, but it's something that has to be operationalized. And some of this is still, frankly, a work in progress, right? So, for example, the penalties on providers, as you know, are not, I think the word in the law is disincentives, haven't, been specified yet, right? So you haven't seen a rule on that, and I'll tell you that's sort of, early work to even understand how some of this would be structured. I think it'll, we want to have reasonable, and I think you can, the test of reasonableness is, I think, reading through the exceptions to information blocking that I think address a lot of the things. We obviously had a lot of public comments on those, so you may, you'll probably see some further nuance in that area based on public comment. So.
Great. So please join me in thanking Dr. Rucker. It was great.
Thank you. Thanks.